Hello, everyone. Thank you for joining today's overview of the 2021 Quality Payment Program Proposed Rule webinar. During this webinar, the Centers for Medicare and Medicaid Services will provide an overview of what is included in the proposed rule for the 2021 performance year of the Quality Payment Program, as well as how to submit formal comments to CMS. After the presentation, CMS will take as many questions as time allows. Now, I will turn the call over to Katie Moore, Health Insurance Specialist at CMS. Please begin.
Great. Thank you, Stephanie. And good afternoon, everybody. As you all know, we are here to talk about the 2021 Quality Payment Program proposed rule. We're all really excited to finally get this out the door to everybody and be able to talk with you all this afternoon on it. So thank you for taking time out of your days to be here with us. We're looking forward to your questions at the end of today's session. And first of all, while I have your attention, and I know we're talking to a number of about a little over 2,000 people on this line, so we're talking to a lot of clinicians and clinician staff across the country, and a lot of our society partners are on the line. So while I have you, I just wanted to say thank you to all of you for all of the hard work you've been doing over the last several months, and as you always do, but really critical over the last few months as our country and our world has been grappling with the COVID-19 pandemic and public health emergency. And we really appreciate just all that you all are doing to make sure our Medicare patients are being taken care of to the best we can at this time. So just want to take a moment before we get started today talking through our proposals just to thank you all from the administration, and we appreciate all that you're doing, and we're really going to try and do all we can to support you. So first, I'm going to just go through a few housekeeping items before we get started into our policies today. So first off, I know folks are always asking about the slides and our transcript and recording, so just wanted to make sure you all know that in the next few days, we'll definitely make all of that available, and it'll be available on our Quality Payment Program webinar library. So you don't have to furiously be writing down everything that we're saying today. We'll all be available later. So you can just sit back and enjoy and take in all that we're going to say today, because I know it's a lot all at one time. All right, we can hop to the next slide. And also, while I have you too, we always like to remind folks that if you haven't already done so if we have some veteran Quality Payment Program participants on this call, I'm sure you're already signed up for our QPP listserv, but if folks are new to the program or just new to our website in general, just want to make sure that you're all signed up for our QPP listserv. So if you go to our main website, qpp.cms.gov, at the bottom of the page, there's a place to put in your email address, because that is definitely how we get out the most up-to-date information about the program or send notifications out. So I want to make sure everybody signed up for that. So the slide you have right here, we just wanted to pull out and highlight. This is really, really important. Our whole program is based on taking into account our stakeholders' feedback into our program, and then adjusting the program so that it's really meaningful to how clinicians are participating, and that we're doing all we can to support you and making this program make sense for how you practice, and making it easier for you to participate where we can. So it's really critical for us to get your feedback on the policies that we're going to discuss today, and we're going to definitely go through our Q&A and love to talk to y'all or talk to you through chat that is also available. But what we really need is for those comments to be submitted through the formal rulemaking process. So as you'll see on the screen here, we need those comments submitted officially within 60 days of when the rule posted. So we'll probably say this several times throughout the presentation today. October 5th is the magic date of when we need all of those comments submitted. And there's instructions here in this slide, and then also all of the information you'll hear today, and then this key information is available in our overview fact sheet that is available on our QPP resource library as well. So please take a look at that resource. It gives you the high-level information, and then you can use that as to then help as you go through the rule. Next slide, please. Great, thanks. This is just a rundown of what we're going to cover today. So I'll turn it over to Brittany in a minute, and we'll go through our Quality Payment Program overview. So just a few high-level slides to ground us all and remind us about the structure of the program. Then we'll get into our Merit-Based Incentive Payment System, MIPS overview, which will go through our MIPS Value Pathways, MVPs proposals for this year, for 2021, just some general MIPS proposals, and then our brand new Alternative Payment Model Performance Pathway, as we call the APP. We'll hear more about that soon, and then we will transition over into our 2021 proposed policies for advanced alternative payment models. And then we'll round it out with our Medicare Shared Savings Program. Our Shared Savings Program colleagues will give some information on what's going on with that program for our accountable care organizations. And then we'll end with just a few help and support information on what resources are available to you all right now, and then we'll get started with our Q&A session. And we do have a number of our subject matter experts on the line today, so they'll be able to answer questions over the phone when we're able to chat. And then throughout this presentation, as other folks are going over different information, the Q&A chat box is available, and our SMEs and other experts are answering questions as we speak. So please feel free to put your questions there. We'll try and pull them out during the Q&A too if we see a large number of the same kind of questions coming through. All right, and with that, I think the next slide, please. All right, great. With that, I'm going to turn it over to Brittany LeCouture to start going over our QPP overview.
Thank you. Hi, this is Brittany. So I'm sure most of you are familiar somewhat with the QPP program and the two tracks, but just as a quick refresh, there are two tracks in the Quality Payment Program. One is the Merit-Based Incentive Payment Program, and the other is Advanced APM Participation, specifically qualifying APM participation or QP status, which is a means of being exempted from MIPS for those folks who have sufficient levels of participation in an advanced APM during the performance year. Next slide. So what is an APM and what's the MIPS eligible condition? APMs are alternative payment models that reward healthcare providers for delivering value-based care, and that value-based care can be tied to a health condition, care episode, or a beneficiary population. And within QPP, we sort of recognize three different types of APMs. Of course, there are more out there, but for our purposes, we're looking at just run-of-the-mill APMs that could mean really anything, any type of arrangement that exists that is run through or in partnership with CMS. And then in QPP specifically, we look at APMs and APMs, and it's worth noting that beginning in 2021, all advanced APMs are also MIPS APMs, and all MIPS APMs are also just APMs. So for purposes of improvement activity scoring or scoring for MIPS APMs or MIPS APM participants, it's good to know that if you're in an advanced APM, you're also in a MIPS APM. If you're in a MIPS APM, you're also just in a regular APM, and so you get the, you get all the benefits of all of these different levels, depending on how far up the chain you go towards advanced APM participation. Next slide. So again, when we talk about MIPS-eligible clinicians, it's really important to understand that with very few exceptions, all participants are MIPS-eligible clinicians unless they're eligible for an exception from MIPS, and that could be because of low volume threshold or any of the other exceptions that exist within MIPS. But the one that most of the examples are concerned with is your QP status. In order to be a QP, you have to have sufficient levels of participation in the advanced APM. So you have to cross the QP threshold. But just because you are in an advanced APM does not necessarily mean that you're not a MIPS-eligible clinician. So it's really important to understand all aspects of the quality payment program and where you fall within it. Next slide. And again, just some background, as we're developing our policies around the quality payment program, these are the kind of things that we have in mind as we're developing those policies. So our goals are to improve patient health outcomes, to improve their care, advance use of health information technology, and to help empower patients and beneficiaries and their caregivers in finding the right, appropriate, and best care that's available to them. And of course, it's for us to always be improving on the quality payment program year over year, whether that's by collecting or analyzing or otherwise using much of the data that we're collecting each year. Next slide, please. Okay, and here I'm going to turn it over to Molly to give more of an overview of the merit incentive payment system.
Okay, thanks, Brittany, and thanks again, everyone, for joining today. Hopefully folks can hear me all right. We did get your guys' notes about that you couldn't hear Brittany too well, so we are getting that worked out so you guys can hear her better for future slides. If there's any questions over the APM or the 2 tracks of the program, we're happy to go over those during the Q&A. So let me go ahead and jump into some of the MIPS basics. Again, for those of you who have been participating in the program for many years or supporting the program for many years, this will be background information. So let's go ahead and move on to the next slide. Okay, so again, when we think about the 2 tracks, I'm going to focus on MIPS for right now. Under MIPS, so prior to MIPS, there were 3 legacy programs that clinicians had to participate under. All of these have since ended, but elements of these 3 programs still exist today under MIPS as well as under our other track of QPP, alternative payment models. And if we go to the next slide. Here we have laid out our 4 performance categories. And as we think about both the MIPS and the APM program, you'll see similarities on what clinicians are being asked to do with these 4 performance categories. So we have quality, cost, improvement activities, and promoting interoperability. Clinicians under the MIPS program are required to participate under all 4 of these 4 performance categories. And based off of their performance under those 4 categories, they receive a score under each category, and that results in something that we call a final score, which can range between 0 and 100 points. Depending upon where that numerical value, that final score is in relation to a performance threshold, that will determine how much reimbursement clinicians would receive in the 2023 payment year. So for the 2021 performance period, which is the focus of our presentation here today, the performance threshold that we've proposed is 50 points. You'll hear me talk about that later on, but just to flag that up front, that's the number that we've proposed for 2021. And depending upon how clinicians would perform in relation to that performance threshold, that would determine their negative, neutral, or positive payment adjustment. So let's go ahead and move on to the next slide, where there's some additional basics on how we talk about clinicians. So when we talk about clinicians under the MIPS program, We talk about them in the context of their TIN and PI combination. So we view clinicians based off of that unique TIN and PI combination. So if, for example, a given doctor has one NPI, but they have more than one TIN, so let's say they work the majority of their time at a hospital, but then they have a private practice unassociated with that hospital, they could have multiple TIN and PI combinations. We would look to determine whether or not someone would be eligible and then therefore required to participate and what their scoring rules would look like based off of each of those unique TIN and PI combinations. Some of the other background pieces that I want to make sure folks are tracking to is when we talk about the performance period and the payment years. So the performance period of 2021, that's what we'll be focusing on here today. That relates to the payment year of 2023. And the total amount of money that we can distribute under the MIPS program for the 2021 performance period moving forward is up to 9%, subject to a scaling factor to maintain budget neutrality. Okay, let's move on to the next slide, please. And just some additional basics of what our timeline typically looks like. So the performance period typically ranges for the 12-month year for some of our performance categories. Some of our other performance categories, there's a 90-day period during 2021 where you'd be able to participate under. The majority of data submission would then happen the following calendar quarter after that. We would then issue feedback around the summer and then begin adjusting claims in 2023. Again, this is the high-level timeline of what things could look like for the 2021 year. Okay, let's go ahead and move on to the next slide. And then it should be the one right after that. I just want to give you guys a quick update regarding our MIPS value pathways. Okay, so again, for those of you who are returning QPP users, the concept of a MIPS value pathway would not be new because we've been talking about this for about the past year to 18 months on our transformative approaches to the quality payment program, really based off of feedback that we've been hearing from all of you. So for those of you who have made your way through the entire rule, you will see that we did not make any proposals that would actually have reporting beginning on an MVP in the 2021 year. Instead, we've delayed that, where 2022 would be the earliest time reporting on an MVP could occur. Again, we have been working with many of you to gather feedback on this new transformative approach to the MIPS program over the past year to 2 years. And we were making progress on collaboratively working with folks on building out some MVPs. But of course, then the pandemic happened. So our plans have been a bit delayed, but we overall feel that this will really allow clinicians to be able to focus on the items that are in front of them right now, which, as Katie mentioned, which is really focusing on the well-being of your Medicare patients as well as your other patients. So again, we have delayed the implementation of MIPS value pathways until 2022. But with that being said, we do have some MVP proposals I want to touch on. We have made some proposals regarding revising the guiding principles that we outlined in last year's rule. So we are looking for feedback on our proposals there. We also have outlined within the rule our process that we would look to have with stakeholders as we collaborate on the development of the MVPs. So you'll see within the proposed rule there's a fairly extensive set of criteria that we would be looking at as we review each candidate MVP, and a set of questions that we'd be asking ourselves as well as you all. And we've also included within the rule a high-level outline of what we envision that candidate submission process would be and moving that forward. So again, while we haven't been able to introduce any MVPs themselves as of yet, we believe that these proposals that we have included will continue to move the ball forward on developing MVPs so they can be introduced in a future year. So with that, let me go ahead and move on to the next slide. and turn it back over to Brittany if she's back online. Brittany, are you there?
I'm here. Can you guys hear me better now?
So much better. Thank you so much.
Okay. I don't know what happened. I didn't change anything. Okay, let's keep going. So eligibility rules and MIPS for 2021. Next slide. Not very many changes are going to be happening in 2021. No changes to clinician types, low volume threshold, determination period, or the opt-in policy. Next slide. However, there we go. The big changes are coming for APM entities. We are sunsetting the APM scoring standard in its entirety, and we're going to let APM entities participate in MIPS however they want. They can, they would, if finalized, they would have the ability to report on any MIPS quality measures that they choose, and only if they choose. If they don't want to report at the entity level, there's no obligation to be scored at that level. However, with the sunsetting of the APM scoring standard, we're going to be changing the eligibility rules for APM entities and instead only include in the APM entity group those eligible clinicians who are already MIPS eligible, meaning that we won't do low volume threshold determinations for the APM entity. We're just going to look at who in the APM entity is already a MIPS eligible clinician, either at the individual or group level. Next slide. Which brings us to the APM performance pathway for folks who are participating in MIPS APM. Next slide. So since the APM scoring standard will be going away, we have proposed what we're calling the APM performance pathway, or the APP, beginning with the 2021 performance year. And the goal of this is to reduce burden, to create some stability year over year so that we're not always changing the measure sets in the way that everyone's being scored. This should be very consistent going forward. This APP is sort of meant to be a complementary pathway to the MVPs in that it is going to be there's going to be a core set of quality measures that everyone reporting through the APP will be reporting on. The APP is going to be entirely optional. You can choose to report it, you can choose not to, and you can report through any other MIPS submission mechanism or any other measures that you choose to report on. It could also be reported by individuals, by groups, or APM entities, so there's tons of flexibility with the APP. But it is only available for scoring participants in MIPS APM. So if an entity reports that it includes folks who aren't captured on the participant list or anything like that, they won't be benefiting from that reporting. The APP also is going to be what is used by the Shared Savings Program for calculating quality performance scores within the Shared Savings Program, which we'll get into a little bit later in this presentation, but just wanted to flag it now. If you are in an SSP ACO, you will be required to report the APP. Next slide. So the APP does have some scoring differences from the rest of MIPS. The performance category weights will be a little bit different. The quality performance category will be comprised of 6 top health measures that we believe should be widely available to participants in any MIPS APM. So that should create some stability and some ease of reporting for groups or individuals who may be in more than one APM. They only have one measure set to worry about. And that will be 50% of the weight. The cost performance category will continue to be reweighted to 0% for APM participants, again, because we know that you're already at risk for costs within your APM. Improvement activities performance category will be weighted at 20%. And for the 2021 calendar year, all of our MIPS APMs will be assigned an automatic score of 100% based on the requirements of participation in each MIPS APM. And the promoting interoperability performance category will be weighted at 30%. And that score will be based on PI reporting that is done at either the individual or group level. And if you're scored at the APM entity level, we will roll those scores up to create the APM entity level score, just as we've done in the past. Next slide. And I'm going to turn it back over to Molly to go into a little bit more detail. Oh, sorry, I think it's Sophia, about the MIPS performance categories in 2021.
Thanks, Brittany. Next slide, please. Okay, in this slide, we want to give you a compare and contrast of the 2020 performance period to what is being proposed for 2021. You'll notice that the changes in the performance category weight are solely between the quality and cost performance category, where we are proposing to reduce quality to 40% and proposing to increase cost by 20%. By 5% to make it 20%. We just want to note here in this slide that these weights do not apply to the APM performance pathway. Next slide, please. Okay, in this next section of slides, we're just going to go through some of the changes that we have proposed for the quality performance category specifically. Next slide, please. Okay, here we want to make note of several of our proposals, one related and the largest of the quality performance category proposals relating to the sunset of the CMS web interface. So in our 2020 repertoire of collection types available for reporting, we include the CMS web interface, ECQMs, Medicare Part B claims, MIPS CQMs, or MIPS clinical quality measures, previously referred to as registry measures, and then QCDR measures. We have proposed to sunset the CMS web interface, and we do realize that this would be a big change for groups and virtual groups, but we do believe that there is other options, alternative collection types that would be available and would reduce reporting requirements, as groups and virtual groups would be able to then select their own individual measures instead of reporting on a predetermined set. We'll likely have to report on fewer measures, 6 rather than 10, with the ability to report on all payer data. And you also will have the opportunity to report on ECQMs or CQMs of those very same measures that you reported through the web interface. Those measures that were available in the web interface are specified in other collection types, so those measures will still be available to you. Next slide, please. Oh, sorry. A few other points to touch upon before I move forward. Other areas that we've made policy changes to, or proposed policy changes to, are in relation to the MIPS quality measure inventory, changes with regards to the addition and removal of measures. We've also proposed within the scoring aspect or a benchmarking aspect of the quality performance category to use performance period benchmarks for the 2021 performance period. And this is with the realization of the current events of the United States and in light of the pandemic, and in understanding that there may be some data that we receive in 2021 that cannot compare to previous years, or our use of a historical benchmarks. We've also, through this rule, have proposed some policy changes to our quality scoring to establish additional flexibility. Next slide, please. Okay, and focusing in on the quality measures aspect, the quality measure inventory, we are proposing to have in total a number of 206 quality measures available for the 2021 performance period. This would account for 112 of our existing measures having substantive changes. There are changes proposed to the specialty sets that we have in the program. We have proposed to remove certain measures from specialty sets. They have perhaps may be replaced with new measures that have come in, or perhaps some of those measures have been signaled for possible removal through the proposed rule. In the proposed rule, we've also signaled 14 quality measures for removal, and the proposal of 2 new measures that are available as administrative claims-based measures There are also outcome-based measures within the program, and those two measures are the hospital-wide 30-day all-cause unplanned readmission measure rate for MIPS-eligible clinicians and groups. That measure would seek to replace the existing all-cause readmission measure. And then separately, we have the risk standardized complication rate following elective primary total hip arthroplasty and or total knee arthroplasty for MIPS-eligible clinicians administered claims-based measure. Next slide, please. Okay. With regards to quality measure benchmarking and topped-out measures, within the 2020 rule, we have used historical data to establish quality measure benchmarks. And when a historical benchmark cannot be created, we attempt to create a benchmark using data submitted for the performance period. When the published historical benchmark identifies a measure as topped out for 2 or more years, then the measure can earn a maximum of 7 achievement points beginning in the second consecutive year that the measure is identified as topped out. For 2021, what we're proposing for a change is that we are intending to use the performance period benchmarks for 2021 using data submitted during 2021 rather than the baseline historical data. And this is because we're concerned that the data may not be representative or comparable to the historical data of previous years because of the COVID-19 public health emergency, and that might lead to skewed benchmarking results. With regards to changes that we're proposing related to 7-point cap, we want to tie the benchmarking proposals by applying a cap of 7 achievement points for the 2021 performance period and beyond to measures that are identified as topped out for 2 or more consecutive years, inclusive of the 2021 performance period benchmark. Next slide, please. Okay. Additional policy proposed changes that we've proposed related to scoring, related to the ICD-10 policy. So within 2020, we have a policy where for measures that are identified as having significant ICD-10 coding changes, we would truncate those specific measures to have a performance period of the first 9 months rather than the full calendar year of 12 months. For measures that have any significant changes with clinical guidelines, changes with clinical guidelines or the clinical guidelines come to be outdated mid-year, we tend to suppress those measures from scoring, which would mean that they would achieve 0 points and the total measure achievement points would be reduced by 10. In 2021, or in the 2021 proposed rule, we're proposing to increase established scoring flexibility by expanding the reasons upon which a quality measure may be impacted. So that might account for inadvertent scenarios where changes to coding may happen, or if changes to measure specs that are something clinically related that are outside of our control or the stakeholders' control, so that clinicians are not inadvertently impacted or negatively impacted by that. We also are proposing to revise an existing policy to give us some flexibility to determine when to allow scoring of a measure with a performance period that's truncated, or to decide whether a measure should be suppressed. And this is really for us to, review scenarios on a case-by-case basis to determine whether whether the data that has been collected thus far for the given performance year can be used for the purposes of scoring and payment, or if we should, if we find that a given scenario will cause harm, to give us that allowance to suppress it, thereby allowing us to avoid any scenario of causing inadvertent harm to a clinician's score. Next slide, please. Okay, for this section of the webinar, I'm going to turn it over to Ronique for the cost performance category.
Thanks, Sophia. So I'll be providing an overview for the 2021 proposed changes regarding the cost performance category. Next slide, please. So as you can see, for 2020, we finalized revisions to the MSPB and CPCC measures. We also retained the existing 8 episode-based cost measures and added an additional 10. We also finalized changes to the approach to propose and measure attribution methodologies by including the attribution methodology in the measure specifications. So for 2021, there aren't any changes being proposed made to the existing measure set, nor changes to the measure attribution methodology. We are proposing to update measures where appropriate to include telehealth services. Next slide, please. And with that, I will pass it over to Elizabeth.
Thank you, Ronique. I'm going to first address the improvement activities performance category. Next slide, please. So for 2021, we're proposing the modification of 2 existing improvement activities. Next slide, please. And then we're also changing some of the criteria and also how we input new improvement activities. So right now we have 6 existing criteria, and we're proposing to establish 1 new criteria for nominating new improvement activities so that activities can be linked to existing and related MIPS quality and cost measures as applicable and feasible, so that we can really better align with the MVPs that we are developing. We're also proposing changes to the pathways, so now we have an annual call for measures where we take in suggestions for new improvement activities, but we're also adding additional circumstances. One would be an exception during a public health emergency. We have already added through an interim final rule with comment an improvement activity related to COVID-19. But we're also proposing to have a process where we as an agency could propose additional improvement activities outside of the call for measures. And this would give us the ability to be more nimble when we want to add new improvement activities. Next slide, please. And moving on to the next slide, now I'm going to address the promoting interoperability performance category. We have a few minor changes. One would be to retain the query of PD&P measure. It will remain an optional measure, but we really believe that this is a very important measure and hope that people are querying PD&Ps. So we are proposing to increase the bonus points available for this measure from 5 to 10. We're also proposing to change the name of the support electronic referral loops by receiving and incorporating health information. Incorporating is not required. You need to reconcile the information and then determine if incorporating would be appropriate. So we're replacing the word incorporate with reconcile. Next slide, please. We're also proposing to add a new measure to the health information exchange objective. This would be the HIE bidirectional exchange measure. This measure would be worth 40 points, and it would be a yes-no attestation. It is an optional measure, so you would either choose the 2 existing measures to report, or you could do the optional measure. You cannot do both. And next slide, please. I wanted to point out something that's not in the QPP section of the Physician Fee Schedule proposed rule, but it is applicable to the promoting interoperability performance category. So in another section of the rule, we talk about updates to certified EHR technology due to the 21st Century Cures final rule. That was a final rule that was promulgated by the Office of the National Coordinator for Health Information Technology. And so this 2015 edition update includes changes to technical standards, such as the standard for e-prescribing, as well as technical updates to 2015 edition functionality, such as moving from the CCBS to the US CDI. There is some flexibility of when these changes need to be implemented. There is enforcement discretion in place so that providers currently have until August 2nd, 2022 to make these changes. Essentially, our proposal is to allow clinicians to be able to use the current edition or the revised edition at any point. So as soon as your vendor rolls out the new edition, you can use that edition if you so choose, and you'll still be in compliance with the certified EHR technology that you have. Next slide, please. And lastly, just to talk about, we are extending our existing policies for automatic reweighting as it applies to all of these different clinician types. And now I am going to turn it back to Sophia.
Thanks, Elizabeth. Next slide, please. One more. Next slide, please. Thank you. All right, I'm going to be going over the third-party intermediary section of the rule, and we'll just highlight a few proposed changes, and I will indicate which third-party intermediaries are impacted. So the first section of this slide here is with regards to data validation. Some of you who are familiar with MIPS and familiar with our qualified clinical data registries and qualified registries may know that data validation is an existing requirement that the qualified registries and QCDRs must submit to or take a part of in order to be an approved QCDR or qualified registry. So in this rule, we are providing more clarity with regards to data validation. We have heard stakeholder questions with this requirement. So the intent of rehashing this policy in this NPRM is to kind of provide more guidance to our QCDRs and registries as to what our expectations are with data validation, particularly in one area related to what was previously known as a detailed audit. We have proposed in this NPRM to change the terminology. So we would refer to what we refer to as a randomized audit previously as now the data validation audit, and that the item that was previously referred to as a detailed audit when QCDRs and registries must audit the data that their clients send to them to submit to CMS for purposes of the MIPS program. The detailed audit will now be referred to as a targeted audit, and this is to provide more clarity as to our intention with conducting the targeted audit. So we have, within the proposed rule, provided more framework and kind of guidelines to provide additional guidance there. Within the NPRM, we are also looking to seek comment right now with the health IT vendors to see whether we should require health IT vendors to perform data validation. Currently, this is something that we will require QCDRs and registries to do, and we're looking to see what stakeholders think of having to require health IT vendors to do this. We do want to note we also consider CAP survey vendors, or the Consumer Assessment of Healthcare Providers and System Survey vendors, another type of third-party intermediary, and they do currently perform a type of data validation, but we still look to hear from you all in terms of whether you feel that we should align the type of data validation that they currently do to the process that's one that we propose for QCDRs and registries, just to kind of create that sense of alignment and ensuring that the same level of expectation is used across the board with all of our third-party intermediaries. So that is an area we are seeking comment on, and we do hope to hear from you all on. The next section is the relation to approval criteria, and this applies to all third-party intermediaries. So that would be qualified clinical data registries, QCDRs, qualified registries, health IT vendors, and the CAP survey vendors. And the additional proposed factors that we would like to consider before we approve a third-party intermediary for future participation in the MIPS program is the entity's compliance with requirements for any prior MIPS performance period for which it was approved as a third-party intermediary. So essentially, we want to take into consideration third-party intermediaries' past performance and before we continue to allow them to participate in the program. And this really helps to ensure that the third-party intermediaries that we have in the program that continue to support clinicians who report in our program continue to be, reliable sources that our clinicians can depend upon to ensure that their data is submitted and it's done in a way that's true, accurate, and complete. Another component of the criteria that we're looking to enforce is whether we could consider the entity's history with providing inaccurate information to clinicians regarding MIPS program requirements. And this goes back to, historically, we've had experiences where third-party intermediaries have misguided clinicians and led them down to a path where they've promoted, for example, cherry picking of data, and that is not something we choose to. We would like to be promoted, especially in a quality program. So we would like to factor in all these historical actions to ensure that really moving forward we have good quality vendors in our program. Next slide, please. Okay. With regards to data submission, overall, there are no large changes with regards to data submission for third-party intermediaries. The one caveat here is related to the APM performance pathway and the MVPs. So for the APM performance pathway, if that is finalized, it will be available starting from the 2021 performance period. So we will allow QCDRs and qualified registries and health IT vendors to support that APP if they so choose to, beginning of 2021. One thing to note is we are aware QCDRs and qualified registries are currently self-nominating for the 2021 performance period, and that self-nomination period for those vendor types ends September 1st, 2020. And so we are aware that self-nomination ends before the final rule is posted. So we are working to create a workaround should this APP be finalized to allow those approved vendors to then opt to let us know whether or not they choose to support the APP. Same can be said with the MVPs beginning with the 2022 performance period. One thing to note is that for QCDRs and qualified registries, our expectations are they support the quality, promoting interoperability, and the improvement activities performance categories. They are required to support all three. The one exception to this is the health IT vendors. If health IT vendors choose not to support MVPs, then they are not required to support all three performance categories and can support only one. If they choose to support MVPs, they must support all three of those performance categories where data submission is required. The cost performance category is, of course, a part of the MVPs, but that does not require data submission on behalf of a third-party intermediary. The last section here is related to remedial action and termination policies, and this impacts all four types of third-party intermediaries. And so what we have in terms of remedial action and termination policies is that CMS has the authority to place third-party intermediaries on remedial action, and as a part of that, we do require those vendors who are placed on remedial action to submit what we call a corrective action plan to correct the deficiency or noncompliance issue. And so what we are doing in the rule is outlining specifically what the corrective action plan must include. And so that the corrective action plan must include the details that contributed to the noncompliance. We want to understand the impacts of the issue, how many clinicians and groups were impacted regardless of their participation status. We want to understand what actions are going to be taken by the third party to ensure that the noncompliance issues are resolved and won't reoccur in the future. And we want the third-party intermediary to also provide us a detailed timeline of how they plan on achieving compliance and by when with the applicable requirements. And those are all aspects that we would consider before we decide to accept the cap and allow that vendor to remain on remedial action until time has passed where they've solved the issue, or if we choose to terminate that vendor. Okay, and I believe, next slide please. The next few items are related to QCDR measures, and this is specifically for our qualified clinical data registries. Through the interim final rule with comment that was published a few months ago, we did go ahead and delay what we previously had for qualified clinical data measures or QCDR measures, the testing requirements. So in the 2020 rule, we had previously finalized that for 2021, QCDR measures must be fully tested in order for them to be considered for the 2021 performance year. However, in light of the pandemic and our understanding of there might be a lack of data collection and that might thereby have downstream impacts to testing, we had, through the IFC rule, delayed that entire policy until the 2022 performance period. Through this 2021 NPRM, we are looking to provide additional guidance, and this is based off of stakeholder feedback, to provide more clarity in terms of our expectations with measured testing. So in this proposed rule, we are proposing that beginning with the 2022 performance period, that we would modify our QCDR measure testing requirement to be essentially a two-step process, where in the first year of a measure, we would only require validity testing to be complete in order for it to be considered. However, in any subsequent year for that measure to be considered, the measure must be fully tested. The other item related to QCDR measures is a item related to data collection. So previously we had finalized that in order for a measure to be considered, we would require QCDRs to collect data on the measure to then demonstrate that there is a performance gap, that the area of measurement is an area of interest to clinicians, and that the measure is actually implementable and collectible. That is another requirement that we have through the IFC delayed until 2022. So we won't be looking for QCDRs to provide us with that information, or we won't be rejecting measures because of the lack of that information for the 2021 performance period. We will start looking for that beginning with the 2022 year. And I will go to the next slide, please. All right, I'm going to turn it over back over to Molly for the COVID-19 flexibilities.
Okay, great. Thanks, Sophia. Let's go ahead and move on to the next slide. And as we're doing that, I just want to share with folks, these slides here talk about some additional flexibilities that we've included within the rule, but I did just want to briefly remind folks of some of the flexibilities we've already issued for this current year, for the 2020 program year. So first, folks will recall back a few months ago, we released a new COVID-19 improvement activity with high weighting that clinicians can choose to participate under for this year. And we also released information about a month to 2 months ago, letting all stakeholders know that for this year, for the 2020 year, we have implemented our application-based extreme and uncontrollable circumstances policy. And what that means is that for individual clinicians, groups of clinicians, and virtual groups, they could come to us today, to our website, and file a application requesting reweighting of one or all of their performance categories if they are not able to participate in the program due to the COVID-19 pandemic. I'll talk about this in a little bit more detail on a future slide because we've been getting a lot of questions related to this. But before I talk about that in more detail, let me just explain what you guys are seeing in front of you. So as many of you are aware, since the second year of the program, we have offered a complex patient bonus, which we automatically calculate for all clinicians who participate in at least one of our performance categories, and typically they can get up to 5 points. And this takes into account the care that clinicians provide to their more medically and socially complex patients. What we have proposed to do is that just for this year, for the 2020 performance period, we will double the number of available points under that complex patient bonus. Whereas previously the max is up to 5 points, we're doubling it up to 10 points. We recognize that due to the COVID-19 pandemic, those patients that are higher risk and have some of those additional complex medical factors as a part of them, the pandemic is in many instances further exacerbating some of their issues. So we recognize that those patients that are already complex could now be even more so due to the pandemic. So again, this is a proposal that we have for the 2020 year. And then moving on to the next slide, here's where I want to circle back to explaining in more detail our application-based extreme and uncontrollable policy that we have for the 2020 year. So again, right now, today, clinicians that are participating under the MIPS program as an individual, as a group, or as part of a virtual group, they can come to our website, qpc.cms.gov, and there's the ability for folks to file a reweighting application due to an extreme and uncontrollable circumstance. And as part of that application, we do ask for folks to provide us with a short justification of why they feel that reweighting is needed, and also to select which performance categories have been impacted. I've been seeing some questions come up in the chat, and we've been getting questions on this on some of our other sessions, so I just want to be clear about this up front. We've been getting a lot of questions on, what type of documentation and support is needed when folks are filing that reweighting application. The key pieces that we really want to make sure that we see and hear within that justification is that folks are impacted by the COVID-19 pandemic public health emergency. Some variation on that would need to be included, as well as, again, how your practice has been impacted. And that will ensure that we can review your hardship application in a short manner. Again, if you do not include reference to the COVID-19 pandemic, it can create delays for further reviews of your application. For other questions related to other documentation that would need to be on file, we're not requesting any of that when you file your application. If you have that available, of course, please keep that on hand, but we are not requesting that when you file your application. So that's our existing policy. What I want to explain here is the revision that we've proposed to make, which is now we are also proposing to allow APM entities for you all to have the ability to request a hardship due to the extreme and uncontrollable circumstance. APM entities, if we finalize this proposal, you would be able to do so at that level instead of at different levels. Also, the other piece that I want to be really clear on is the way that the APM entity hardship application would work. It will work differently than how it would for individuals, groups, and virtual groups. So for individuals, groups, and virtual groups, when they file their reweighting application, that has to be received prior to the beginning of the submission period. So we need to receive that before the end of this year. And if then later on an individual determines, I actually can submit data, we would view that active data submission to void the previously approved application. So again, for individuals, groups, virtual groups, if they request an application and it's approved, and then we later receive data that's submitted on their behalf, that application is voided. The difference is how this will work for APM entities. For APM entities, if they file an application and then they later submit data, that MIPS hardship application is not voided. So APM entities will need to do some additional considerations when they make the decisions on whether or not they want to file a hardship application, because there would not be the ability for that application to be rescinded. Okay, I hope that helps clarify. We also are happy to go over in more detail our COVID-19 flexibilities that we've issued to date during the Q&A later on. But with that, I want to go ahead and move on to the next slide. And then the next slide again to finish up the MIPS portion of the presentation to talk about where we propose to set the performance threshold. Okay, so as I mentioned at the beginning of the call, we have proposed to revise the performance threshold for the 2021 year down to 50 points. As you guys may recall, last year we actually did finalize a performance threshold for next year of 60 points. But again, based off of a variety of factors, one of them being everything that's been happening to us this year, we feel that it's appropriate to lower that performance threshold down to 50 points. We did not make any proposed changes to the additional performance threshold of 85 points. But again, this is a proposal, and we are looking forward to your feedback on this as well as all of our proposals. And so then let's move on to the next slide, where I'll just go over what that distribution would look like. So, okay, so as you guys can see on this slide here, if we do finalize a performance threshold of 50 points, the final scores in the distribution, if your final score is anywhere above 50 points, you would have the ability to earn a positive payment adjustment. And if it's above 85 points, you would be able to earn a portion of that additional performance threshold exceptional bonus. If it's anywhere below, so that's on the positive side. Then on the lower side, so if your final score is anywhere below 50 points, particularly below 12.5 points, automatically you would get a negative 9% adjustment. So we want folks to try to avoid that. So that's, just wanted to call that out. Okay, let's go ahead and move on to the next slide. And the last item I wanted to touch on with you guys here today for MIPS is the proposal that we've made regarding which final score gets used. So as many of you are aware, there is the ability for clinicians to participate in the MIPS program through multiple means. So we do see a portion of our users where some users may participate as part of a group, and then we also receive individual data. Or we also see that sometimes people are part of an APM, but then we also receive data reported from them through another means. Previously, our scoring policies accounted for where we would always use the APM score first, then the virtual group score, and then whatever is the highest. Based off of the revisions that we've made here, including the sunsetting of the APM scoring standard and the introduction of the new APP under MIPS, we felt that we didn't need that additional complexity. So what we propose to have as our new scoring hierarchy is we would use the virtual group final score first. There are statutory, so legal restrictions on which final scores can be used for virtual groups. And typically, and what the law states is that if you participate as a virtual group, that's the final score that would be used. So that's why we have that first in our scoring hierarchy. And then from there, we would use whatever is the highest score. So it could be your score that you received through participation as an APM entity. It could be a score that's received if a separate data is reported as an individual or as part of a group. So let me go ahead and stop there and move on to the next slide. And I'm turning the presentation over to Brittany. Brittany?
Thanks, Molly. Next slide, please. So really quick, just a refresher, to be in an advanced APM, the APM must meet these three requirements: that it requires use of CERT, that it has MIPS comparable quality measures, including an outcome measure that are all tied to payments, and that it requires more than nominal financial risk or is a patient-centered medical home. Next slide. This year, we're not really proposing very many changes for advanced APM, two pretty minor ones. One is to the way that we're going to do QP determinations for, or the way that we treat beneficiaries who are considered attribution eligible in more than one APM or more than one APM entity, where the attribution of those APMs conflict with each other in some way. So basically what we're going to do is if there's a beneficiary who cannot be attributed to an APM entity, we're going to remove them from the attributable beneficiary population. So we're going to take them out of the denominator and make it a little bit easier for those folks to get QP status. The other thing that we're doing is in very, very limited circumstances where there's evidence that CMS has made some form of clerical error in determining participation lists for an advanced APM, we're going to allow targeted review for those folks who think they may have been left off the list. And that's Those are our only proposals on the advanced APM side for 2021. So if we can just keep moving right along, I'll turn this over to next slide. I think that's it. Yeah, let me turn it over to Carla to give you a little information about changes to the shared savings program.
Okay, Carla's on. So I'm going to cover the Medicare Shared Savings Program. And what we want to highlight here is for our performance year 2020, all ACOs will be considered as being affected by the public health emergency due to the COVID-19 pandemic. And so the Shared Savings Program, extreme and uncontrollable circumstances, will apply. In addition, for performance year 2020 only, we're proposing to waive the requirements for ACOs to field the Consumer Assessment and Healthcare Providers and Systems, which is the CAHPS for ACOs survey. So consequently, ACOs would receive automatic full credit for the patient experience of care measures. And then we are also seeking comment on alternative scoring methodology approaches under the extreme and uncontrollable circumstances, where we're considering if the ACO is in their second or subsequent performance year and they completely report through the web interface those measures, then that ACO will receive the higher of their 2020 ACO quality performance score or the 2019 quality score for purposes of financial reconciliation. However, if that ACO does not completely report the web interface measures, then they'll receive the 2020 ACO mean quality performance score. If the ACO is in their first performance year and completely reports, then they'll get 100% for their quality score. But if they're in their first year and they do not report, then they'll receive the 2020 ACO mean quality score, performance score. And so before I leave this slide, I just want to say, in conjunction with the proposed changes to the quality performance standard, we're proposing to strengthen our shared savings program compliance policies by broadening the conditions under which CMS may terminate an ACO's participation agreement when the ACO demonstrates a pattern of failure to meet the quality performance standards. So I'll move on to the next slide real quickly. So for performance year 2021, we're proposing to redesign the Shared Savings Program quality measure set and the quality performance standard. And what we're proposing is that ACOs will be required to report quality measures data via the proposed alternative payment model performance pathway, which is the APP that's been discussed several times throughout this presentation. Under this new approach, ACOs in the Shared Savings Program would only need to report one set of quality metrics that would meet requirements under both the MIPS and the Shared Savings Program. This would reduce the measure set from 23 to 6 measures, and the number of measures on the which the ACOs are required to actively report would be reduced from 10 to 3. However, we would be raising the quality performance standards, so instead of having to achieve the 30th percentile on one measure set for each domain, ACOs would be required to receive a quality performance score equivalent to or above the 40th percentile across all MIPS quality performance category scores in order to share in savings or avoid owing maximum losses. This quality performance score would be calculated based on the sum of the performance across those 6 measures. And just real quick, ACOs would be allowed to use the measures they choose within the APP that is in line with the MIPS submission for data. Next slide. So with that, I want to turn it over to Katie for her to review the help and support information.
Great. Thanks so much, Carla, and thank you, everybody. We're just going to wrap up real quick so we can get into some Q&A, but just this slide information, most of you already know this, but we do have technical assistance that is no cost available for small and solo practices. So please check out that information if it applies to you. And then, as always, our Quality Payment Program Service Center is ready with our agents to answer your questions. So please feel free to contact them if you ever need additional assistance walking through your specific scenario. It's always easier to talk to somebody one-on-one. And then our CMMI learning systems also have some more information available there. Next slide. I think we're just going to turn it over to our team on the phone to help explain how we are. Oh, I'm getting ahead of myself for the QA. Real quick, final reminder again for those comments to any of the proposals we've discussed today or anything you're reading in the rule. We really, really need your feedback. So please follow the correct instructions to officially submit your comments by October 5th. And with that, I'm going to turn it over to our team to give you instructions on how to dial in.
To ask a question, please dial 1-833-376-0535. The number again, 1-833-376-0535. If prompted, use passcode 5093924. Again, the passcode 5093924. Press star 1 to be added to the question queue. You may also submit questions via the chat box. Speakers will answer as many questions as time allows.
Great. Thank you, Stephanie. All right. Just to get started, we have a few questions about the proposed APP. So, Brittany, if you could please clarify, will advanced APMs not transition to the APP?
Yeah, so this is a question I saw come up quite a number of times in the Q&A, and I really want to clarify that being in an advanced APM does not mean that you are excluded from MIPS. Being in an advanced APM only means that you're eligible to earn QP status. And if you're in an advanced APM, you are still a MIPS eligible clinician unless you earn that QP status. So with that said, yes, all advanced APMs are also MIPS APMs, and participants in any MIPS APM are eligible to report via the APP. So this is not a transition in any way. Advanced APM participants have always been required to report to MIPS if they don't achieve QP status. And I do want to point out the QP threshold is going to be going up in 2021 as is required by statute. So a lot of folks who have in the past been QPs are still participating in the same advanced APM, but this year they're going to remain MIPS eligible clinicians. So please keep an eye on that and start thinking about how you would like to participate in MIPS.
Great, thank you. On a similar topic, can you please provide a bit more information on QPs, partial QPs, and criteria for APM participants and the overlap between them? They are requesting more information on which of APMs, MIPS APMs, and advanced APMs would have to do with MIPS reporting.
Yes, it's a very loaded question. So again, if you're in a MIPS or in an advanced APM, you're also in a MIPS APM. If you get QP status through your advanced APM, you're excluded from MIPS and you don't have to participate. If you get partial QP status through your advanced APM, you have the option of taking a neutral MIPS payment adjustment or participating in MIPS and attempting to get a higher payment adjustment. If you participate in MIPS because you're a partial QP who has opted in, or if you don't get QP status and you're just a MIPS eligible clinician, whether you're in an advanced APM or a MIPS APM only, you have the option of reporting MIPS in 2021 however you choose to, but you also have the option of reporting via the APP. Again, that's at the individual, the group, or the APM entity level. So there's lots of options and lots of flexibility for reporting to MIPS in 2021 if you are a MIPS eligible clinician, meaning that you have not achieved QP status.
Great, thank you. And additionally, I read this is a question, if MIPS APMs don't report via the APP, there is a consequence with a MIPS score that includes cost, and they won't get 100% for improvement activities. Can you please confirm if there is a consequence for MIPS APMs not reporting via the APP?
So if an APM entity chooses not to report via the APP, that doesn't necessarily mean anything. It could mean that the individual or the group that the individual is part of, they can report the APP and still get all of those same scoring rules as are available in the APP. If the APM entity does decide to report to MIPS, but they choose to report some other way, whether it's a future MVP or they report on other EC2Ms or however you choose to do it, that's fine. You will not have the cost performance category reweighted to 0. And you will need to report on the improvement activities performance category. You'll get a 50% credit for APM implementation, but you'll still need to report on at least one more measure to get to 100% in that category.
Great, thank you. Okay, will MSSP/ACO submit quality data through the QPP website under the APP? What will the actual submission process for the APP look like?
Hey, this is Brittany. So as Carla mentioned, reporting through the APP, oh, Carla, if you want to take it, go ahead.
Oh, no problem, Brittany. You can go ahead.
So reporting through the APP, we'll have a mix of different types of quality measures. We'll have the CAPS measures, some claims measures, and some EC2M. That said, each measure has its own reporting mechanisms and requirements. And so you're going to have to take a look at those measures and report them in any way that is supported for that measure. So looking at the actively reported measures, you can use a registry or an EHR or any of those other methods of reporting, whereas CAPS, of course, will still be reported via vendor, and claims measures are claims measures. So you just have to look at the individual measures requirements, and you can use any mechanism that is available through MIPS. It's your choice.
Great, thank you. All right, Stephanie, do we have any questions on the phone line?
We have a question from Jason Shropshire.
Hi, can you hear me?
Yes, we can.
Hello? Hi, I have a couple questions. So first of all, based on what Brittany just said, I now have a follow-up question. So I think what the last caller was asking is for clinical quality, let's say the hypertension measure that is still in place for the APP. So when you're in an APM, you're saying now we cannot self-report that as we used to through the web interface. You're saying the only options to report the clinical quality measures are now through a QCDR or qualified registry or electronically. We cannot self-report that number ourselves. Is that true or not?
Yes, that's right, because the web interface is being sunset at the end of 2020.
Okay, great. Thank you. And my next question is, so do advanced APMs with QP status have to report promoting interoperability under this new rule, or is it like before where they're exempted from that?
It's like before.
So again, APMs and APM entities do not get exempted from MIPS. Qualifying APM participants who are eligible clinicians at the individual level are exempted from MIPS. So when you go to report the APP, if just no one reports on the PI performance category, that's fine. You'll earn a score of 0. And if everyone in your ACO happens to be a QP, then it doesn't matter because none of them are getting a MIPS adjustment. But if you have even one person who missed the snapshot date and ends up with a MIPS score, then they're going to need that reporting to get them a higher score for the PI performance category. So it is still part of the scoring. It's going to be counted, but when it comes to your payment adjustment, if you're a QP, it doesn't really matter. Does that make sense?
Yes, and then one last question. So I asked this in the chat, but the answer I got didn't make sense. So groups who have previously reported CMS web interface, can they report the APP in 2021 for MIPS quality? Or the only options now to report quality are just QCDRs, QRs, and ECQM?
So groups can report the APP, but they will not be able to report through the web interface.
But they can report APP, and that counts for
I feel
MIPS?
like I'm not answering your question. I'm sorry?
So can they report APP? Will that count for MIPS? Or in essence, I'm really asking is if
yes.
the APP, yes, they can.
Yes, if you report the APP, it counts for MIPS and it counts for SSP, so you only have to report that one thing the one time.
Okay, thanks.
Hey everybody, this is Katie Moore. I'm just going to hop in here real quick while we're getting our next questions. So lined up on the phone or grab from the chat. I know we have a ton of questions we're seeing through the chat, and like Jason was just bringing up about web interface sunsetting after. So just wanted to highlight that we are working on some transition resource for everybody that'll kind of help explain, I think, a lot of the questions you guys are asking. And then we're also planning for, not sure how many, but some webinars this fall to talk with everybody and get your feedback on, what information would be most helpful in that resource we're working on. But definitely want to have a specific time for all of the web interface transition questions. So just didn't want folks to worry that this is it and you're not going to get your questions answered. So we will be having some specific education and outreach sessions this fall specific for web interface transition. So more to come there. And one more thing on web interface, I did see a couple questions in the chat about, is web interface sunsetting mean that the entire QPP website? That is not true. Those are two totally different things. There's our qpp.cms.gov website, and then as you all know, there's a way to log in to our website. So that functionality is not ending. It's just this specific reporting mechanism for CMS web interface that will be ending. So thanks. I'll turn it back over to our Ketchum team.
Great. Thank you, Katie. Okay, we have a few questions on the extreme and uncontrollable circumstances application. So can you please clarify what exactly is needed for that, and would they need to submit something for each performance category?
Yeah, hi Lauren, it's Molly. Let me try to talk us through this one in a bit more detail. And I want to share with folks as well, we do have a resource on our website. If you go to qpp.cms.gov, just on the banner there's at the top of the website, there's a link to our COVID-19 fact sheet. I do want to flag that it includes all of the COVID-19 flexibilities we've issued to date, but not those that were contained in the slides today. Since again, that's just a proposal and we've just gotten the rule out, we haven't yet had an opportunity to update that fact sheet. But that's a great resource and it goes over some of these more detailed questions of where to go and everything to file that reweighting application. But overall, what we're looking for is clinicians, they would need to provide to us a justification on why they believe that reweighting is needed, and they have the ability to request that for either one or all performance categories. What we typically see is that a clinician's justifications, as in I can't participate in the quality performance category, it often applies to other categories as well, but we don't want to presume that. So we do want to have an understanding of, is this an issue that is impacting folks' ability to participate in just one or all of the performance categories. But so there is that ability for that to be included within the reweighting. I did also see a couple of questions come over within the chat, and just in case I wasn't able to get to all of them, questions regarding the voiding of an application. So again, it differs for individuals, groups, virtual groups, and APM entities. The way it works for individuals, groups, and virtual groups is that if they file a hardship application by the end of this year and then they separately submit data to us for the following calendar quarter, that would be voided. The exception to that is if the only data we have would be the data that we calculate internally, so for cost data and for our administrative claims data. I did also see a couple questions come over regarding what happens if someone was reporting on Part B claims, or maybe their EHR needs to use those QDC or G codes that come in on Part B claims, and would that override their application? I'll share with folks, I'm tracking that it does not, but I will go back and double check our rules just to see if there is a nuance there that we need to provide clarification on. And I think that's everything I wanted to touch on regarding the extreme and uncontrollables, but if there's more questions, please send them over our way. Thanks, Lauren.
Great. Thank you, Molly. Okay. Also, just a note to the audience, we know it is nearing 3:30. We will be able to stay on for a few minutes past 3:30 to address a few more questions that we have coming in and on the phone line. So if you're able to stay on, we will try to address as many as time allows. We did have a few questions on the MVPs as well. So will MVPs require ECQMs and CQMs, but these vendors need to be approved as qualified registries as well as a vendor?
This is
sure. Go ahead, Sophia.
Sorry, Molly. So I had mentioned in my response that MVP could be made up of measures that are specified through multiple collection types, so they might be available as ECQMs or as CQMs and ECQMs. We do have a limited number of Part D claims measures, but again, looking at the availability of measures, we did also propose in the rule that starting with 2022, QCDR measures could be considered for inclusion in MVPs. So there are a multitude of ways in which those measures can be reported. QCDR measures can only be reported through QCDRs. However, CQMs, MIPS clinical quality measures, can be reported through a qualified registry or utilizing another submission method called direct upload. And I believe there's additional technical details on that in our QPP resource library.
Great, thank you. Okay, great. Stephanie, do we have any more questions on the phone line?
We do. The next question is from Catherine Camino-Samata.
Hi, can you hear me?
Yes, we can.
Okay, so my question is relating to group reporting under MIPS. We have a large multi-specialty practice that has reported as a group in the past. Most of our providers use the same electronic health records, so we're able to capture quality data as well as PI data and so forth. We have a small subset of about 5 providers that are orthopedic providers that up until this point have been documenting on paper. So we haven't been able to contribute anything to the PI category for them, nor collect quality data on those providers. The question is, they are going to be going up on a separate EHR that particular vendor is a qualified registry, and so they can submit MIPS ECQMs. Can we still report as a group, submit 6 EHR ECQMs from the large portion of the group and 6 from this new group this group of 5 that are going on in the next couple of weeks onto the EHR, and will CMS look at both of those from a group perspective and give us a score on the top 6?
Hey, Catherine, this is Molly. Let me try to address this one. So I think I'm hearing you explain a scenario where you have, well, let me ask one question. For your group, are you comprised of one TIN or multiple TINs?
One TIN.
Okay, so with it being one TIN, the way that it would work is, so I'll just do easy math. Let's say it's a 50-person group. one TIN, the majority of your people are reporting on a common set of 6 measures, but then a subset of that group is reporting on another set of 6 measures. But they're still all within the same TIN. What you can do is you can separately report each set of those data to us, but we would look at the higher of the data that has been reported by your TIN. So actually, I don't know that. So actually, you'd be submitting data for us for, conceivably in this example, 12 measures, 6 that are related to your portion of your group and 6 for the rest of your group. Is that answering your question?
Yes.
I'm not sure if.
Yes.
Okay.
Yes. That was my question. I had contacted the QPP twice about this and gotten conflicting answers. The first time I contacted them, they said, yes, you could do that, and we would just take the top 6 that scored the highest to contribute towards your score. The second time I called, because my vendor questioned that, and the second time I called, they said, well, no, for that smaller subset, you should just report those folks as individuals because otherwise you wouldn't have data completeness. Well, I'm not going to have data completeness anyway because they're not going on the EHR until, the first part of September.
Okay. Kathy, why don't we do this? I see that you submitted a question in the chat. I'm going to reply and give you my email address, and why don't we talk about this more offline? I think there may be some additional nuances that I don't want to give you incorrect information on the phone here today. So I'll go ahead and do that. So thank you.
Yep, thank you very much.
Okay, great. Thank you, Molly. Okay, next we have a few questions about the individual performance categories. What happens with regards to the cost performance category if a provider does not have any patients attributed to them?
Hi, this is Veronique. I can take that one. So the cost category in that instance, it will be reweighted to 0, and the other categories will be reweighted. So there's a set of reweighting rules. If you don't have a measure in a particular category, you can find it on the 2019 scoring guide in the QPP resource library. So in general, if you don't have any cost measures, your quality performance category will be re-rated to a more heavy weight.
Great, thank you. Okay, and concerning third-party intermediaries, can you please confirm if QCDRs, is it true that QCDRs must be able to support the submission of quality measures, PI and IA, starting in 2021? Is that correct?
That is correct.
Great, thank you. Okay, Stephanie, do we have any more questions on the phone line?
We do. Our next question is from Heather Harper.
Hi, this is Heather Harper, and I'm calling from Carroll County Nephrology. We're a nephrology practice, and I have a feeling this is probably only going to apply to a nephrology practice, so I'm not sure if this is something you want to talk about offline. I have called in as well to the QPP, and it's been elegated, or there's a ticket number and it's been moved up because the answers I'm getting do not make sense. We currently participate in the ESCO program with our dialysis entity, and the ESCO is being phased out, as you're aware, and they're going to have the kidney care choice models. We had initially signed a letter of intent to go with the kidney care choice models and are choosing to back out of that, just want to participate in MIPS. I was told by the QPP that we have to start that this year, October 1st, 2020, but we're still in a contract with our dialysis center under the ESCO past that time frame.
Yeah. Sorry, I don't know where that answer came from. So if what you're looking for, if you are in an ESCO for calendar year 2020 and you're not QPs, right? If you're QPs and you're going to get your 5% incentive payment, you don't have to report to MIPS. If you're not QPs and you do need to report to MIPS, and you may be losing, depending on the exact situation of your termination from CEC, you may lose QP status, and that's maybe what you're referring to.
Yeah, that's what we don't want to. We don't want to be in the QPP anymore.
Okay. Okay. Well, I mean, the Quality Payment Program is a mandatory program, and you're either going to be in the Advanced APM track or in the MIPS track. Currently, as a CECF, you are in an Advanced APM, and you're eligible for the QP status and that incentive payment. When you terminate from that APM, you will lose your QP status, and you will be required to report to MIPS. This isn't optional. This is a mandatory program. When you report to MIPS, you will have been captured as participants in an APM during the performance year, so you'll still get some scoring benefits because you spent most of the year in an APM, but you still will have reporting requirements. You'll have to report on the quality performance category, and you'll still be promoting interoperability performance category for 2020.
So then what I'm hearing is that whenever our current the ESCO expires, which my understanding is they extended it to March 31st of 2021, would we be able to, because I was also told I can't overlap, that because we're the QP status under the ESCO, we cannot participate in both at the same time, and that's what you're telling me, correct?
Yes.
So,
okay. Until 2021, and then you will keep your QP status for 2020. And this is really scary. If you need more help with this, you can reach out to me directly or ask for the APM folks if you call the help desk, because this does get super weedy in these very nuanced circumstances. So I'm happy to more detail with you offline with that.
Okay, so I'm sorry. I don't know if it's your phone or mine, but it broke up. I need to ask exactly for what because I have the case out there.
Just ask to be transferred. Just ask for me or for Tanya Dorm, she's our help desk lead. We can help you get sorted out, or you can just email me directly. It's brittany.locatore@cms.hhs.gov.
I'm sorry.
Hey, Heather.
Can somebody put that somewhere?
Yeah. Hey, Heather. This is Katie Moore. I'm just sending you Brittany's email through the chat.
Thank you so much. And I think that once the contract ends, it doesn't matter whenever the contract ends, we would automatically be required to report in the MIPS.
That's right.
Okay.
Okay, great. Thank you for that. Okay, we have time for just a few more questions. Okay. So just to finish up, Brittany, can you confirm if a preferred provider of an APM, not a participant provider, are they required to report under the regular MIPS program or under the new MIPS APM rules?
Oh, I love this question. Yes, so beginning in 2021, we are expanding the definition of MIPS APM, so it will now include folks who in the past referred to as secondary providers or affiliate practitioners, people who are in models like CJR, an expanded population of our BIPSI Advanced participants. So basically, if you are directly affiliated with any MIPS APM, and so you turn on either a participation list or an affiliate practitioner list, and depending on your APM, you may be called a participating provider in that case, you will be able to benefit from your APM participation, and you will have the option of reporting to the APP.
Okay, great, thank you. And one more question concerning the APP. Is to clarify the 40th percentile requirement, will that apply to each measure or all measures combined into one score must exceed the 40th percentile?
I think that's actually a shared savings program question. Carla, can you take it?
I'm sorry, can you repeat the question?
Yes, of course. Apologies for that. It's concerning the 40th percentile requirement that has changed. Can you clarify how MSSP ACOs will be scored on the APP quality measures for minimum attainment? Will the 40th percentile requirement apply to each measure, or will all measures combined, will they need to exceed the 40th percentile?
Okay, so across all the measures. So to meet the qualification, the ACO would need to receive a quality performance score equivalent to or above the 40th percentile across all the MIPS quality performance category scores in order to share in savings. So for SSP, we're going to look at the 3 measures for APP, but then you'll also be required to do the caps for MIPS. The caps for MIPS, and then 2 claims-based measures. And across those 6 measures, it needs to be a 40th percentile or above.
Okay. All right. Thank you for that. It looks like that is all the time that we have for questions today. So thank you, and I will turn it back to Katie Moore to conclude this webinar.
Great. Thanks, Lauren. Thanks, everybody, for joining us today and hanging on a little bit longer. We wanted to try and get to as many questions as we could. Just a reminder, our slides, transcript, and recording from today should be available in the resource library, in our webinar library. So keep an eye out for that and all of our other materials on the resource library. And thank you all again for participating today and hanging on with us a little extra time. We appreciate it. We'll talk to you all soon.
Thank you. This concludes today's conference call. You may now disconnect. Please have a great day. Speakers, please hold the line.